This
For the
conference
skills
will now
station,
be recorded.
for the skills stations, they can show you anything. They will show like 7 or 8 different items they can show you. They can give you a CTG. They can give you some other devices that comment on them. What are these? Why we use them? They can show you different surgical instruments. They can show you sutures. They can bring like IUCD.
Take for doctora, it's there in the room. Yeah. You took for doctora? Take for doctora, it's there. I'm carrying all.
This conference will now be recorded.
Hello.
Yes, yes.
Like for this first station, they will give you multiple tasks. Like if we have this CTG, so they will ask you that can you comment on this CTG? I will enlarge it for you.
Yeah. Yes.
So this is the CTG. They didn't give you any patient any info on the patient. They just gave you their CTG, and they will ask you to comment on this one. So, what do you think? What's happening here?
Yes, we comment on the CTG depend on the Dr. C. Brovado mnemonic. And first, we should take a brief history and determine if there is any risk factors for that patient, if she is having preterm labor, if there is infection or meconium or IUGR or any to identify if there is any risk. Okay, and then we will comment on the contractions. The patient, she's having some mild irregular contractions, like 2 to 3 in 10 minutes, and 2 to 3 in 10 minutes. And then for the fetal heart, it's the baseline is 120 beats per minute. With good variability, it's about 5 to 10 beats per minute, and there is some minimal some accelerations are there, and there are some variable decelerations. It's about almost more than 50% of the contractions for the trace, which is about maybe this is 30 minutes. About 30 minutes. So it is like one non-reassuring sign. So it's non-reassuring. The overall is non-reassuring CTG.
Okay. So, they just ask you that comment on this CTG. Okay. So when you want to comment, I agree with you that we use that mnemonic, Dr. C. Bravado, that we should determine the risk, and then we should proceed. That there are contractions, what is the baseline, so and other things. So when you comment, you are asked to comment on any CTG. First thing you should say is, do you have any patient identifier here? The name should be here. Okay. Then what is the date? Date and time, they are very important. Date is mentioned here, 11/1/2005. And then you should see the paper speed. It is mentioned here, if you can appreciate, 1 centimeter per minute. Because if we don't read the speed, because in some machines the paper will run at 2 centimeters per minute, so we can misinterpret. Okay. So you are good when you said that we need we need a brief patient history. So this is a skill station, so they will not give you details. They will just ask you to comment on this one. So now tell me that what sort of decelerations are these? You will say that there are decelerations. What is the baseline for you? This is 100, 120.
120.
Yeah,
120.
Because it's in the reference range. So you can see D cells. So what sort of D cells are these?
These are
If you will look
variable.
at this, Yeah, these are variable. So, and then you should see that what is the duration of this recording. So it has been continued for like 15 minutes, right? So you should say that this is a trace of the fetal heart for 20 minutes, 30 minutes, or whatever the time duration. And these are the findings that there are variable decelerations. And I can see that there are mild contractions, and she's contracting at a rate of 3 in 10 minutes. So the next question is, what action you should take now? If someone is having a CTG like this, then what action should be
How many?
taken?
Yes, okay.
So what should we do now? Because this CTG is not a good one. We
Mm.
have some concern here.
No, but if it is less than 30 minutes, then we cannot say that is non-reassuring. We have to extend more the CTG at least for 30 minutes to can decide if this deceleration continues or not. But if suppose this is already 30 minutes trace, we have the same trace, so it is for 30 minutes, these decelerations are there, then that is non-reassuring. So we should start resuscitation. We will check the patient temperature. We will give her IV fluid. Maybe she is dehydrated. We will keep her on the side position. And if she's on syntocinon infusion, then we can reduce the syntho or stop the syntocinon and watch the CTG. And if it is improved, then that will be fine. If it didn't improve, then we can go for depend on also the what is the gestational age and what is the VE findings for her. If she is more than 4 centimeters and she is more than 34 weeks, then we can go for fetal scalp sampling. If it continued like 50 minutes like that, then we can go for fetal scalp sampling.
Okay. Okay, thank you. That's how you should comment on this CTG, because this is just a skill station, so they will not give you extra time, and there will be at least 5 tasks. Okay, can be more, but usually never. I've never seen them that they are asking about like 5 or 6 things. Usually they will keep like 7, 8 tasks will be there. So that's why we have to be, uh, you know, we don't have to go into details. We will just comment on that. Okay. Thank you
Yeah,
very much. Dr.
welcome.
Zaida,
Yeah. Hello?
how are you? Hi, good
Yeah,
morning. How are you?
good morning, Dr. Aisha. Yeah, yesterday I couldn't catch up with you all because I was held up. I was on call yesterday. That's it.
Okay.
Hope I get the
This
recorded
is,
session
yeah, this is
yesterday.
also a problem for the doctors. Very
Mm.
hard to prepare
Because
in the
suddenly at the
beginning.
last moment, yeah, I requested a leave. So they just gave me today and the first day. Anyway,
So let's hope that we can make good use of this time.
yeah.
So today, we are talking about skill stations, that what
Mm-hmm.
sort of things they can show you. Okay.
Okay.
So here is one report.
Mm-hmm.
This is the condition of the patient, her description. So you can see
Mm-hmm.
that once you finish reading this page, then please tell me. I will scroll it, this
Okay.
paper, and then you can read the rest of the station. So they're basically asking you that what's wrong. Can you find any abnormality in the test results?
Mm-hmm.
So they will give you normal ranges also. Okay. So don't be in a hurry. Just have a look at the report and then see that is it still in the reference range? Okay. Or it is mildly increased, moderately, or severely increased.
Yeah.
So she's RH negative.
Yeah.
So
Platelet count is
platelet count is 10, 180. No,
100,
it's 80 only. 80.
80. Okay.
And fibrinogen level is 1.8.
Okay.
So what do you think?
Patient is anemic still, and yeah, her hemoglobin is 8.9. With postpartum period, it should be at least 10. Okay, and her PT and APTT is a little on the higher side. So since she has bled quite a lot intraoperative and postoperatively, likely could be a DIC, but platelet counts are also on the lower side. It's about 80, and the WBCs are on the higher side, which is 29. So some foci of infection can be there, and yeah,
So you think we need to give her anything?
urine is clear, draining equally, minimal blood loss, most recent blood test. We need to build up a hemoglobin, but they are not very less. It is on the lower side, maybe oral iron therapy. And I would like to know about her vital signs and her temperature and pulse as well to rule out, because the WBC counts are on the higher side. So just to know if there's any infection, and her PT and APTT are on the higher side, is raised. So again, and she has a minimal trickling of blood, and could be patient is in DIC.
Actually, if we will look at this one, APTT is
39
slightly
on the
elevated.
higher
It should
side. Yeah,
be within 34, so it is going to the higher side. So outside
platelets.
this
Yeah,
normal range.
yeah.
Platelets, okay. And this
Slightly
fibrinogen is
low.
1.8. So we
Yeah,
need to
but
give
not
her,
less than. She's not
yeah,
platelets are not less than 50, so I don't think she requires a platelet transfusion. But fibrinogen is above 1.5, so that's fine. But PT APTT is raised. No, Dr.
this is
Media
elevated.
fresh
So,
frozen plasma. Yeah. Mm.
forming time also,
Not
slightly elevated.
1.5 times. Yeah, not more than 1.5 times raised. It is less than 1.5 times. Mm.
So do you think she needs fresh
I
frozen
think we need,
plasma?
yeah, fresh frozen plasma and need to build up a hemoglobin. I think that will help her to reduce the little trickle of bleeding. But platelets need not be, because it's okay. It doesn't follow the criteria for the transfusion.
Yeah, that. And fibrinogen level should be kept at above 2 grams per
1.5. Yeah.
deciliter. So, this is, they are giving this reference range, but the recommended one is 2. So we need to give her fresh
Yeah.
frozen plasma.
Plasma. Yeah.
Because no, anyhow, she is urine is clear, everything is fine,
Mm.
and but she had this main risk factor for hemorrhage, so that's why she had, it was significant hemorrhage.
Mm.
That is it. Okay, so it gave her fresh frozen plasma. So
Mm.
maybe DIC is setting in.
Mm.
Okay, thank you. Next
Thank
case is for Dr. Asma. So what is her problem? What is the abnormality in the report? I think, can you hear me please? Okay. I think Dr. Asma is not there. So anyone would like to comment on this one? Is the abnormality in this report?
Which one, Dr. Aisha? This one. Assalamu
Yeah,
alaikum.
good morning. Welcome, Sam. How are you? This
Fine. Yeah. I woke up 7 and then I slept again.
it's okay. It's okay. The way you are here.
Yeah. 19-year-old Caucasian in her first pregnancy, compliant with antenatal care, staying in a women's hostel for the homeless. She smokes 20 to 25 cigarettes, intravenous abuser, and methadone withdrawal program. Her booking hemoglobin electrophoresis HbA and H2. 36 weeks pregnant. So her MCV, hemoglobin is low. Then the white cell count is high. Platelet count is okay. MCV is low, and PCV is low, and MCH is also low. So it looks like she has all the parameters for hemoglobin and absolute values are low. So she has anemia, and because all parameters are low, there can be possibility of thalassemia also. But we have to differentiate from iron deficiency anemia and thalassemia.
See, her booking,
Where is
yeah.
where is electrophoresis?
Yeah.
The
They said
normal
that,
levels of okay. Yeah, so this is iron deficiency anemia then.
yeah.
Severe
I,
iron deficiency anemia because it is 7.7 hemoglobin.
yes, this is iron deficiency, but the thing you said first, that by definition, thalassemia, we will call it thalassemia. Uh, in case of thalassemia, patient will have anemia in the presence of all normal indices. That is the basic definition of thalassemia. Okay, so this one satisfies that definition because this will
Can you repeat, Dr. Aisha?
that your patient will have normal parameters, like they will be
Mhm,
on the lower side, but still they will be in the reference range, and
mhm.
still your patient will have anemia. So then you have to think about thalassemia.
Okay.
Only this. But in cases here, your main clue should not come from this hemoglobin level. You should focus on MCV.
MCV.
That is the basic criteria. Here they are saying 78 to 100. Okay, this is for the sake of exam. But if
Mhm,
you go to the normal levels, like international levels, they say that if MCV is less than 70, think about microcytic anemia. Between 70 to 90, that is the reference range. More than 90, think about macrocytic anemia, which can be due to deficiency of folates or due to deficiency of vitamin B12. So basically, this girl is anemic, and she has, her. That's why they gave you all this description that she
mhm.
was an addict, and she is, you know, underprivileged. She is
Yeah, care
homeless
home. She's in a
and
care home.
malnourished. So she's having this. Her food is not good, so she has this anemia.
So less than
Before
70 micro, you said that we think of this one iron deficiency and 70 to 90, no, sorry, less than 70 microcytic.
yeah, less than
70 to
70 micro
90
normal.
normal and 90 and above, we think of macrocytic anemia.
Microcytic anemia can be folate deficiency or vitamin B12 deficiency, like a person is pure vegetarian. That is the point. So
In
we are
thalassemia, I think MCV is not that much low, I think,
yeah.
in
That's
thalassemia.
what they will be in the. That's why I said that in thalassemia all blood results will be normal, but
Normal.
still your patient will be anemic. That is the point. Okay, they will be.
But it will
I'll
be
put
in the lower range, I think. All the absolute
lower
values in the
range. It
lower
will be in
range.
the lower
Yeah.
range. Like MCV will be maybe 72, 74, even 78. Okay, but still
Okay.
your patient will have signs and clinical signs and symptoms of anemia,
Anemia.
fatigue,
Okay.
tiredness, and they will have, like, if we will talk about thalassemia also, because I have some slides to show you. We'll talk about that also. So basically, we are practicing these skills. They can ask you different type of questions. Like we started here, I will just show you that first we commented on CTG. Then we talked about another patient who just underwent this C-section and she had placenta previa and accreta and significant hemorrhage. Cell salvage was done and this is her result. So here activated partial thromboplastin time was raised and then this WBC count is 29.8. So after cesarean section, WBC count can be up to 25,000. You will not think that that is abnormal because there is excessive stress on the body, acute stress. So WBC count can rise tremendously. 16,000 in case of normal delivery is accepted as normal, and in cases of cesarean section, 25,000 is the normal limit. So
But
we are
here
going
fibrogen
to,
is less than 2, so she will
yeah.
need
So
cryoprecipitate
we should give
because it
her
is
fibrinogen also.
cryoprecipitate. Yeah,
Yes, that's
cryoprecipitate.
correct. Because Irish guideline says from the start that it is preferable that if fibrinogen level is kept towards the higher level, so we can give her fibrinogen. Okay,
Yeah. Even
that is
RCG
the
also changed to 2 gram per liter, because
yeah,
before it was 1.5, now they changed to 2 gram per liter.
two. Yes. So we are going to stick to this new information that it should be kept at 2. And so anything which is deficient, you will say that if this level is low. So then they will ask you, so what should be done? You will say that give her fibrinogen. So since it is a skill station and you are going to answer like 7 to 9 questions, they are going to show you slides in a rapid sequence. So don't have to go into details. Okay.
But
Just
Prashna, show
complete
the
all.
CTG one, the first one, the CTG one. The,
There is no
this
history,
is
nothing.
early decelerations. Early decelerations, these are the.
See, this one I will say is early, but
Mhm.
this one,
Like we can say that we will comment like following the DRC bravado, and we will just we can for the time being say early, and then we will continue the CTG. If still it is like this, then we will reassess the patient.
so before you they commented that some of them were variable also because I can see that 2 or 3 are early and but if you go for this one here, this one is slightly late than this one. If you will go to this one is also the maximum point is different. So we said that we have like 2 3 variable D cells and 2 3 early D cells. So like I just told them that first you have to see that patient identifiers are there, then what is the paper speed, what is the time
Yes,
here, what
yes,
is the
time
date,
here, yeah.
and the paper speed is very important. Otherwise, you can easily misinterpret it. Okay, so this is the CTG, and then see for how long this strip is given. What was the duration? If you
This
will
is
give
in
the
between 2 lines, 10 minutes, and then 1, 2,
yeah
3, 4, 5, 6, 7. It is 17 minutes almost.
yeah, so it should be like it should be more than 30 minutes, or preferably it should be for 45 minutes to comment on this one. But if you find any abnormality, you should take resuscitative measures. Don't leave the patient alone. Okay? We will not wait for the 45-minute period. We will start resuscitation.
Like we
So
will
we
do
will,
left lateral and IV hydration. I don't know,
yeah,
in RCG they are not giving oxygen. In RCPI they
yeah.
are giving oxygen.
RCPI guideline is just like the 2007 intrapartum care guideline by NICE, okay, like the old NICE guideline. And as you know that RCOG, this new NICE guideline also went back to that previous guideline, second edition of this guideline. So again, 110 to 160 and variation of 25 to 5 weeks. Then and but they are still considering these accelerations. There should be accelerations, but as we know, accelerations are not there, okay, and there should be no decelerations. So they also say that you have to give oxygen, but now it will have no effect on the CTG. It will just correct hypoxemia in the mother. That's why they will
Yeah,
give
yeah,
oxygen.
yes.
Otherwise, no effect on the baby. Okay, Dr. Asma, are you there? This is the third
Uh,
question.
yes,
Okay.
doctora.
Yeah, so this patient is, this next test result is for you. They can show you different results. We will also practice with different investigations, but today I am showing you these anemias, um,
Mm.
blood reports for different
Yeah.
patients.
Mm-hmm.
Dr. Asma, you will look at this one and then you will comment that what is the abnormality in this case.
Yes. That is a postpartum patient who had a postpartum hemorrhage. She lost 600 ml blood and she fainted, and then she looks pale. Normal blood pressure, pulse rate is normal, and the uterus is contracted. Lochia is normal, breastfed and all. Okay, her hemoglobin is 8.6, so definitely for postpartum it's low, because it's written here 11.5, but postpartum it is 10. The normal hemoglobin should be 10. WBCs is little high, so this is accepted for the postpartum patient. Platelet is high also. MCV is 80, that is normal, and MCH is 29, that is all normal. Yeah, and platelet and WBCs are high.
Your opinion on platelets.
Hmm?
What about the level of platelets? It is
Yeah, it's a
525
high.
in
This
base
is what I'm saying.
9 per
It's a
kilogram.
high thrombocytosis.
Thrombocytosis.
Mm,
So what do you suspect here?
just wait a minute. Yeah, thrombocytosis. What can be the cause of this is due to hemorrhage. Maybe. Yes. Mm.
So
No,
you
I'm
have
not really sure. Mm.
no problem. Don't give up. Just think logically. She is
Mm.
anemic. She
Mm.
has some side effect. She's on the postnatal ward. They didn't mention here that she had a cesarean delivery, right? Then if the platelet count is so high, so there is thrombocytosis, and the blood flow will be sluggish. So at 8.6 hemoglobin, she will not be symptomatic. She's 33, young woman, right? So most likely
Mm.
the blood is very thick, and maybe she will develop a clot, and blood flow is very sluggish. Okay, so you should get, and she has infection also. Maybe she's, first of all, before starting any treatment, you have to see that how she's behaving. Like, what is the clinical condition? Is she dehydrated? Because if you look at BP, the diastolic is 66, still normal, but towards the lower side, and the pulse rate is fine. Okay. First of all, you need to see that the patient is well hydrated or not. But obviously, there is some infection and this high platelet count. So maybe she has some thrombophilia, some problem is there, or maybe hemoconcentration is there. So she should be fully evaluated, and maybe she will need some heparin, low molecular weight heparin. So you should get her review, send her blood for culture and sensitivity, and antibiotics should be started for her.
Mm. So,
Had a
yani, the
rotation,
possible causes are infection or dehydration.
infection, dehydration, because they are telling you
Mm.
100 ml postpartum hemorrhage, and she had a rotational forceps delivery. So rotational forceps deliveries, they are associated with, sometimes they are associated with significant trauma, and her uterus is involuting, so they told you that there is no hematocarpus, nothing. So,
Mm.
but this report shows some infection and maybe hemoconcentration because the platelet count is very high. So we need
Mm.
to dehydrate the patient, and we need to start antibiotics, and she should be reviewed by the hematologist because 525 is very high.
Mm.
That's
Okay.
She can have sickle cell, Dr. Aisha, if
uh,
but
she
electrophoresis
can
is not
have
given. So, sickle cell
sickler
anemia.
and sickler, and also in cases of thalassemics, again the platelet count can be up to 600. So, but they didn't mention in the history. So that's why I said that give her IV fluids or let her drink to her thirst, and then send blood for culture and sensitivity and see what is the clinical condition. But if they ask you about the abnormality, there are two things are abnormal: very high WBC count, and second thing is thrombocytosis. Should be reviewed by the hematologist, because they didn't give us any history, anything, so we need further evaluation for this patient. But if they ask you to spot the abnormalities, these are very high WBCs and very high platelets. So, and then this one looks slightly relatively unusual, because in cases of rotational forceps deliveries, usually the hemorrhage is greater than this one. So we don't know if he has a hematoma or some problem, but they didn't mention anything. So this patient needs full evaluation. But if you are commenting only on these blood counts, then there are two abnormalities.
But we will say anemia also, because 86 hemoglobin, like mild anemia.
Yeah, all these three parameters are abnormal: mild anemia, and at this blood level, if at this hemoglobin level, if your patient is symptomatic, so you think you should give her blood or you should investigate her?
Yeah.
We will not
Then
give
she may
blood.
be maybe she is compensating if she is not symptomatic. Then after some time she can have.
She can desaturate, so maybe she has
Yeah.
some, this hematoma, because why they told you that she had a rotational delivery? It was more traumatic. So evaluate her full inspection, examination, and then if she's febrile, because they didn't mention her temperature, they just gave her, if you look at this one, she looks pale, so she has evidence of bleeding. Okay, so this is the blood pressure. She's trying to compensate for it, and pulse rate is also fine, but they didn't comment on her temperature, so we need to take her temperature also, because maybe she is febrile. Okay? And she's symptomatic, maybe she is dehydrated and she's looking pale, maybe she's forming a hematoma. So this patient needs full evaluation, and then we should get her reviewed by the hematologist also, to see that why this platelet count is very high. Maybe undiagnosed thrombocytosis, or maybe she has some hereditary thrombophilia, maybe she is thalassemic, or maybe she has but in sicklers hemoglobin will not be this much, especially after
Yeah.
an
Yeah.
episode of heavy bleeding. See? So that's why, to answer one question, you have to recall so many things. Okay. So in the lab results, they will just show you some results, and then they will ask you that what is the abnormality here? What should be done next? They are like single best answers, that start IV antibiotics, hydrate her, and get a review by the hematologist, and exclude hematoma formation, because she is looking pale and she is symptomatic. And she was feeling dizzy, feeling faint after going to the bathroom. So can be postural hypotension also. So these are the abnormalities. So first we have to start with the simple measures. Send for further investigations. Take her temperature first of all. But for the diagnosis of fever, it is not essential that the temperature should be high, because the patient should have other symptoms also. Okay? We agree that the temperature on two occasions, if it is more than 37.5, then we have to think about fever. And sometimes, if the temperature is 38, we will not assume that she has some infection. Maybe it's around 20, or sometimes due to effects of presence of this progesterone, temperature can be high. So always you have to correlate vital signs with the clinical condition of the patient and her history also, that what exactly happened, and then after combining all of these things, then you can reach some conclusion. My reference is this RCG guideline on maternal collapse. It says that if you see that temperature is 38, don't assume that she has a fever, she's running a fever, or she has sepsis. Pay attention to other vital signs also. So here to begin with, check her temperature, send blood for culture and sensitivity, start IV antibiotics, and correct if she's dehydrated, and after that get her reviewed by the hematologist. Okay. Dr. Zahida,
Yeah,
are you?
yeah, Dr. Aisha. Yeah.
Yes, please. So they will show you a picture, or they can actually show you some different types of forceps or vacuum,
Mm-hmm.
and one instrument. Okay, they can ask you what is this. So can you tell me what's going on in here?
This is a forceps delivery. Uh, mm, it's a the arrow showing towards the forceps. I'm outlet forceps.
Yeah,
It has got a like they want me to explain the forceps in this. It has got a shank handle.
yeah.
Then what are the indications, contraindications, and criteria?
So basically, they are asking you once you will say that this is they are trying to deliver the baby with forceps. So what are they
Forceps.
contemplating?
Uh,
Instrumental delivery.
uh, yeah. Okay.
So
It's
then
a
this is at mid cavity level or outlet forceps or what?
yeah outlet for it is at the mid cavity level. Outlet forceps we don't use right nowadays.
Mhm.
Do we?
Yeah, sometimes they do. You know, they will use these Wrigley's or outlet forceps sometimes when the head is
Mm-hmm.
not coming, or if they need a traction of like the less than 45, then they will use the outlet.
Mm-hmm.
In in our countries and in Gulf, they don't use forceps very frequently, but in the Western world, they are still using all different types of forceps, and vacuum is not used very frequently.
Mm-hmm.
This is the difference, okay? Even for
Okay.
weave, not usually use vacuum extractor, but they will use these forceps, okay? So
Mm-hmm.
basically, they are. So you should say that they are mimicking the movement, natural movements, and they are going in a reverse J or inverted J fashion. So then they can ask you, yeah, you should know about the indications. When do we offer instrumental
It's
delivery?
got maternal fetal indications for forceps delivery. Maternal indications, yes, poor bearing down, cut short second stage in case of cardiac diseases like NYHA class 3 and 4. Then fetal indications like fetal distress. Then uh, then
You know, when the head is there, she is fully dilated and
hypertension, severe hypertensive crisis. Yeah.
severe hypertension. You can do that. Whenever you want to shorten the second stage of labor, you can do that. So you should say
Yeah.
that you can do because of maternal indications, or you can do because of fetal
Fetal
indications. Maternal
indications.
indication, exhaustion, okay, or she
Mm,
has some medical condition due to which she
mm,
cannot continue
push.
pushing, and
Mm,
Valsalva maneuver is not good for her. Okay, like he is a
mm,
cardiac patient, but in grade 3 and grade in
okay.
class 3 and class 4 of New York Heart Association classification. Due to fetal reasons, if there is fetal distress and
Fetal
you need to
distress. Mm,
accomplish delivery in a quick way in less than 30 minutes, so the benefit is that in cesarean you will still take some time, but here you can achieve it quickly. So what are the prerequisites for doing OVT?
First thing is that prerequisites. First, patient's bladder should be empty, lithotomy position after taking informed consent, verbal consent, and head should not less than 1/5 palpable per abdomen. Membrane should be ruptured. Then proper position of the sutures should be assessed, and there should not be excessive caput or molding. Then uh, then
Bladder should
patient,
be empty.
presentation should be properly identified.
Mm-hmm.
Then and neonatology should be informed, and in case of failure, the theater should be kept ready. for operative for cesarean section. And a person who has got an expertise in doing a forceps delivery and have attained sufficient competency should do it. And it can be done in the theater or it can be done in the labor room, depending upon the criteria.
Yeah, and you will take consent from the woman. Yeah,
Yeah.
and you need to explain to her that what exactly you are going to do.
Mm.
And membranes should be ruptured, and there should be no contraindication to vaginal delivery.
Delivery.
Yeah, so then we can proceed. So, how many different types of forceps we can use?
We have the outlet, the mid cavity, and the rotational forceps. High forceps we don't use.
Yeah, that is so. Actually, when we are talking about the indications, so head should be at +2 station or more. And
Mm.
if it is at +2 or more, then you should see that you will do this delivery in the delivery speed. If it is between
Yeah.
+1 and +2, you will go to OR. Or if he needs
Theta.
affection more than 45, go to the theater.
Oh.
And if the hair is about between 0 and +1, then you should abandon this idea and you should go for a cesarean section. So then another thing, you should always mention this abdominal palpation also. Most of the candidates, they will just talk about the findings on VE, but you need to tell them
Mm.
that you will do this
Mm.
abdominal examination after evacuating her bladder, and you will see that where is the fetal head. If you can feel 1/5 of fetal head, then still you can apply forceps. But if you are able to feel 2/5 of the fetal head, then you should abandon this idea of instrumental delivery because head is way high. So you need to deliver by cesarean section. Then go to the vaginal examination. See that she is fully dilated, head is well applied, membranes have been ruptured. She has no contraindication for vaginal delivery, and she is suitable, and you will respect her wishes. So then you will do that. So what is the advantage of using forceps over vacuum?
What is the advantage of forceps over the vacuum? Yeah, I think with advantage it is quick
Mm-hmm.
compared to the forceps, and failure rate is less compared to the vacuum delivery, and it can be applied in preterm
Mm-hmm.
above more than 34 weeks, and
Yeah. Yeah, I will agree with you that if it is baby is less than 34 weeks, you can apply forceps, but vacuum should not be applied. Then second thing is, whenever you are doing a vacuum extraction, you need mother to push with you. She will have a
mm,
contraction, she should push and then you should pull. So maternal effort is required. But if she is unable to push, like if she has a cardiac disease, or she is down, she was starting this anesthesia for her. She is drowsy, she cannot push. So then forceps can be applied. That is a benefit because for forceps we don't need any maternal efforts because you are just going to pull the baby with contraction. That is the basic difference, okay? And then the types you were justified in saying that we have rotational and non-rotational. So for the non-rotational, you can have low cavity outlet forceps like Wrigley's, and which are short and light, and they are used when the head is on the perineum at +3. You just have need a little effort to lift the head out of the pelvis. Mid-cavity forceps, they can be of different types. You don't have to remember their names. Just say that we use when the sagittal suture is in the anteroposterior plane or at least not more than 45 degrees from the midline. That is for the mid-cavity. Then we can use rotational forceps and mostly Killand forceps. These are used. So they have a reduced pelvic curve and it will allow rotation about the axis of the handle. So where you need rotational deliveries, you will use Killand forceps. If they ask you to identify, then you see this is a Wrigley forceps. You can see the curves and short handle because we are just using for the outlet deliveries. Level bars we are using in cases of nowadays, I've never not seen anyone using them, but previous indication was these are used to deliver the after coming head in cases of presentation. And this is Kiran forceps. You can see the locks, the shaft, that you can lock it, and they are heavy and they have got long with this shaft and handle also. So if they ask you to describe, forget that what is the name of his forceps, just you should tell them these are the blades,
Plates.
curves,
Sometimes.
this is the shank, this is the fixed block, and this is the handle. So if they ask you which blade you will insert first, so you will insert the right
Left
one or
plate.
the left one? Or the
First the
left one?
left blade, followed by the right one.
Yes, that's correct. And then you should know that what should be the position. This is the correct position, okay? It should be like, if
Equidistant.
we have a lateral view, then you will find something like this. So if they give you a dummy and doll, always say that you will take consent, you will explain the procedure, what is the benefit and what are the risks. Benefit is that we can achieve a quick delivery if the baby is compromised. Disadvantages are that she can have vulval and vaginal tears. These are two different things, okay? And then she can have thyroid force to give perineal care, and baby can have this facial nerve palsy, or they can have marks or bruises on their forehead or the. That's all you should use them. Then rotate them and take them. Okay, thank you. Next one for Dr. Fariha.
Yes, Dr. Aisha. Dr. Aisha, just can you repeat the stations again? This one, you told the stations and forceps.
Yeah, come back. They will just show you this one. They will ask you what's going on here. Stations, the present, where is the head? If it is at between, the head is between 0 and +1, then you should not do instrumental delivery. If it is between +1 and +2, then you should take the patient to the OR, and you will use maybe this rotational forceps. If it is +2 or +3, then you are going to conduct delivery in the delivery room, and you will use outlet forceps. If the head is at 0, you should just abandon this idea of instrumental delivery and go for a cesarean section.
But this chelants will be applied 1 and 2, in between 1 and 2.
Yeah, between 1 and 2,
1 and 2.
between +1 and +2.
1 and plus 2.
We usually think that even this mid cavity is accessible and delivery can be contemplated, but sometimes it is really very hard even with the chelent. So in such case, that's why we do such deliveries inside OR, so that if any problem or it fails, then we should go for cesarean section immediately. And this should be done by a senior trained person, preferably by a consultant, and inside OR.
So head should be 0/5 palpable, and station should be
Even
+2.
yeah, even 1/5 palpable, you can do this forceps or instrumental delivery. Okay, but if +2, then you should not do.
But 1/5 they say usually senior should do, because I think the trainees are not doing
Mid
chelants.
cavity. No, train keelant means consultant. Okay,
Consultant only.
and inside OR, the trainees are doing only outlet forceps. And vacuum is very rarely used. And I have seen even the registrars, they cannot, even consultants, sometimes they cannot use this vacuum.
Mm-hmm.
They can't even apply it on the correct position, the correct side. So, these instrumental deliveries are very important throughout this Ireland and UK. And they will do, if there is any problem, they will take help of forceps. And vacuum is used rarely, but forceps, they are used very frequently. Like I said, even for VPAC, they will prefer to use outlet forceps because they are the quickest way to achieve a delivery. Similarly, if they give you someone where they give you a case where there is already some fetal distress, like the fetus is having bradycardia. In that case, also don't apply forceps because it can also, since it will cause vagal stimulation, so again your baby can have further bradycardia. So in that case, also you should use outlet forceps or mid cavity forceps depending upon the station of the head. It is the point. So if they will bring any of these things, they will ask you about the indications, contraindications, and you should not be worried. Sometimes they will simply ask you that which handle you are going to introduce first. So you are going to put the left one first and then the right one, then lock them and then pull them out with contraction. Okay. And don't forget to say you will have a dummy, but you should say that you will take consent. You will explain the risks and benefits, and then you will proceed. Regarding the consent guidelines, actually you don't have to remember them. You are supposed to mention just the main problem. Fetal fetal injury can be there, hematoma can be there, can be more some this serious hemorrhage can be there. So you have to take permission from the patient. So
Okay.
and feel more fetal concerns with the vacuum. So you have to mention just couple of points and you're fine. Don't have to remember full consent guideline. Just mention 2-3 points. Dr. Priya, it's your turn. What do you see here?
Yeah, this is this stylistic cup ventus, and the down it is the kiwi omni cup.
So, what is the benefit of using kiwi?
Kiwi basically it is available on in the easily available, and it is handy, and everyone can use it. It does not require special training, but it can be applied, and it cause less trauma to the mother and to the fetus.
So, where should it be applied?
Where should what?
What is the point where you will apply this cup? If you are doing any type of vacuum extraction, any sort of instrument like you are using kiwi, you are using stylistic cup, where you will
Flexion
apply this
point.
Yeah,
flexion
we will
points, where
apply.
is the
Yeah, we will
flexion
apply
point?
the flexion point, which is the 6 centimeter, 3 centimeter anterior to the posterior fontanelle and 6 centimeter behind the anterior fontanelle. Basically, it is the vertex, and
Yes.
at that point we should apply the kiwi cup.
Okay, so if you cannot determine the position of the head, do you think that we should proceed with operative delivery, instrumental
No, we
delivery?
should not. Then we
We
should
should.
not proceed. Yeah, we should not. We should either call the senior, or we should prepare the cesarean patient for cesarean section.
Yeah. So we have some contraindications for using vacuum extraction. So can you tell me about some contraindications for the use of vacuum extraction?
Yeah, Ventouse should not be used if it is preterm pregnancy, like less than 34 weeks. In between 34-36 weeks also we have to be cautious, and if it is face presentation, and then if the mother has infections like HIV, hepatitis C, herpes, there is relative contraindication. And then if there are inherited bleeding disorders in the mother, then also we should not use operative vaginal delivery. And also if the baby is suspected to have fetal alloimmune thrombocytopenia or osteogenesis imperfecta, in those cases also we should not apply the ventouse or forceps.
Yeah. So thank you. So there are specific contraindications for the use of vacuum extraction, which include fetal position is undetermined, fetal head still above the ischial spines, malpresentations such as face or breech, then inability to achieve a proper application of cup, then prematurity if the baby is less than 34 weeks, suspected fetal breathing problems, assisted delivery under general anesthesia because you need maternal efforts. Okay, so if she's under general anesthesia, still you can do this forceps delivery, but not vacuum extraction. Then
What is the
any
reason?
If you are using
Okay, patient is not pushing. Okay. Patient
patient
will
is not,
not,
but
yeah,
patient
okay.
is under general anesthesia.
Anesthesia, okay.
Like you are doing a CS, but you think that head is very low. You examine her again, and the head is better than before, so you will apply forceps. And since you don't need maternal effort, you are just going to pull the baby out, so you can use forceps. So it will be a contraindication for using vacuum extraction if the patient is under the effect of GA, because she won't be able to push, and we need her to push if we are doing a vacuum extraction. Then if she has any contraindication to maternal pushing, like in cases of class 3 and class 4 heart disease, that is the point. You will answer just in one line or two lines, because they are going to show you at least 7 items. So that's why you
Okay.
okay, like this. Okay,
So
thank
it
you.
will be a 10-minute station and they will
Yeah,
show
10
many
minute
things.
session. Yeah, as we practiced yesterday with labor board and OR list prioritization, so they can give you a document, they can give you an audit, or they can give you some protocol, patient info leaflet, and they can ask you to comment on that. Okay, that is the reason. So for that, you will have a rest session usually before the scale station. So you will sit there, and then they will ask you different questions.
So
They
if
can
cardiac disease or hypertensive disease grade 3, 4, then we should apply forceps, not ventouse.
yes, that is the point. Use forceps, don't use vacuum. We don't have to go into details. Yesterday we talked about repair of this third-degree perineal tear, so that was enough. You don't have to go back to your guideline and read everything. Okay? Just remember the basic things. Okay. Then Dr. Asma, are you there?
Yes, doctora, I'm here.
What do you see here?
Yes, I see an ultrasound, no, sorry, X-ray image for the uterus, probably that is HCG examination, hysterosalpingogram. And this is a test which shows us about the uterine, give us informations about uterine cavity and tubes, patency of the fallopian tubes, and it uses the radio opaque contrast. There is oil-based contrast. There is also fluid-based contrast, but now we are mostly using the fluid-based because it's more convenient and it's also no delay in having the post spillage image in the X-ray. And in this here test, it's showing like it can be either bicornuate or it is septated uterus. Incomplete septum is here, and there is from the right tube there is a spillage of the outside the tube, but there is also like dilated tubes. It looks like maybe hydrosalpinx is there, but the left tube is completely blocked. There is no spillage, and the tube cannot be seen here on the left side.
Okay. So here they have done hysterosalpingography. Okay. So
Mm.
maybe this one looks like a bicarbonated uterus. Why I will say that? Because in bicarbonated uterus, if you will pay attention from the carnal end of the uterus to the middle point, the distance should be 1.5 centimeter. So this one looks like more than 1.5 centimeter, but we don't know exactly.
Mm.
So in cases of septate uterus, there should not be this much wide gap. Okay, it should be less than this one. So they
Mm.
will be closer, but there will be a defect. So bicarbonated
Mm.
uterus.
Mm.
So RCOG said that we should not be doing hysterosalpingography anymore. We should do saline infusion sonohysterography. But for RCPI, you can still offer hysterosalpingography. So then they will ask you, what are the indications for doing hysterosalpingography?
This is mainly the main indication for infertility. One of the infertility investigations to check the patency of the tube and the cavity if there is intracavitary lesion. Also, it can show us any lesions like intracavitary polyp or fibroids. Um, um, that's it. Dilated tubes before the infertility treatment also, if as before IVF, like an indication if there is a hydrosalpinx. This is one of the indication to do salpingectomy or before going for IVF treatment.
Okay. So can we do other tests to assess tubal patency?
Yes, there is hysterosonography also, which is using a normal saline, and that will be under ultrasound guidance. And also, if the patient is having any morbidity, like history of infection or history of operation, abdominal surgery, before we can do laparoscopy and dye test.
Okay. So will you like to do any test on patient before going for hysterosalpingography?
Yes, we should do screening for the sexual transmitted infection. We will take swabs, vaginal swabs and endocervical swabs before, or if the patient doesn't agree for swabs, we can cover her with antibiotic before doing the procedure.
Okay. So do you think you should exclude pregnancy before doing this procedure?
Yeah, of course. Yes, yes, sorry.
Yeah. So
No,
that is the first.
actually, the timing of hysterosalpingography, usually we do it like 8 to 10 days after the period to avoid the period of the ovulation and possible pregnancy. But of course, it is definitely we need
Yeah.
also, we cannot guarantee, so we need to do a pregnancy test before.
Yes, you should do that, and then they will ask you next question: in which phase of the of a cycle you will do this test? So then you will say immediately after periods, like in the
Mm,
first 10, 11 days of the cycle.
yeah.
So, and then if they ask you about the patient selection, then you should say that if the patient has no history of comorbidities like PID, endometriosis, in that case you should do uh, hysterosalpingography or saline infusion sonohysterography. So, but if patient has history of comorbidities, they will ask you what type of problems, endometriosis, PID, so or history of multiple surgeries, then it is better to do mini lab and dye test. Then another thing you can do for them is fertiloscopy. You know, you can have a look at the tube, laparoscopy, hysterography, and then you can put, this you can put fluid from the posterior fornix or the pouch of Douglas, and it will highlight everything. You will just infuse water, and then you can see the whole structure. So fertiloscopy, but this is not used in the routine practice. So
Philosophy.
yeah,
Philosophy. We do it,
Laparoscopy, you will look, yeah, you will look at the tubes. Laparoscopy,
but
hysteroscopy, yeah,
that one we see it from outside. Yani we don't see inside the tube. We just see
yeah.
it from inside the
So
pelvis only.
that's why
Mm,
phalaproscopy, because you should be able to visualize the tubes. That's why,
mm,
and then hysteroscopy also to see that there is nothing inside uterus. But that is
mm,
not used in common practice. So
mm,
you are just using this mini laparoscopy test if she has any history of surgery, adhesions, PID, endometriosis,
mm,
and if no history, then you will go for hysterosalpingography. So then they will
mm.
ask you that which substance has been used here. So we have used. So what do we inject if we do hysterosalpingography? We will use,
Um, it's radio opaque. It's contrast. Yani we
yeah, instant
contrast.
transfer. So
Mm,
then they will ask you, will you like to tell something to the patient? Then, like you said, they can develop allergic reaction or they can have even anaphylaxis or renal failure. So we need to tell the patient before doing anything. Okay?
mm,
And then they will ask you that, so what is your diagnosis here? Bicarbonate uterus, and there is spillage from the right side, but the left tube is blocked because no peritoneal spillage here. So next, Dr. Fariha. Thank you, doctor. So Dr. Fariha.
You're welcome.
Yes, Dr. Aisha.
Yeah, what do you see here?
Here I can see the imperforate hymen.
Okay, so how can your patient present?
Yeah, patient will basically patient will be a young female who will be in the age of puberty, and she will present with cyclical pain or pain lower abdomen or urinary retention, and she can have severe pain also. And then we have to ask her history, and then we, with her permission, then we will examine her. So basically, she will have cyclical pain and pain lower abdomen, and she can present with urinary retention as well.
Okay, so if you come across a person like this who has this imperforate hymen, how you would like to fix that problem?
First of all, we will explain to the patient that usually she will be younger, so accompanied by parents, and then we will explain to them that this is the problem, and she is basically having cyclical pain because she is having her cycles, but the blood is not coming out. So there is a membrane which is covering the hymen, and so we just need to give a incision in the hymenal membrane, and then she will be fine. So we will take her for examination under anesthesia after consent in the operation theater, and then we will do a cruciate incision in the membrane. But usually it tends to make adhesions again. So then what we do the cruciate incision, and then we do the buttonhole so that
Yeah,
it remains open.
yes, that's how we can fix the problem. So
And
when
then we
if
will call her in the next cycle again to review that she is fine or it has closed again, because sometimes there is a chance that it can happen again.
yeah, that's great. So can there be any other sort of obstruction in the passage in the vagina?
Yeah, there can be longitudinal or transverse vaginal septums, and they can also, matlab, they can present at any age, and patients sometimes can have problem with the periods, or they can have pain during the periods, or they can have like dyspareunia, pain during sex, and they can present at uh, any time.
Yes, that's correct. Okay, so look at this one. This is the normal person, okay? Normal, like you
Yeah,
will
this
see
is
that
normal.
your
Yes.
patients, okay? There is no obstruction, nothing, okay? So, so these patients, they will present with primary amenorrhea, and there can be first causes. You have to exclude local causes, okay? Like here is imperforate hymen, which is a hymen is like a double fold of epithelium. So it is blocking the passage, okay? Then, here you can appreciate another blockade here. If it is like this, then you will say there is segmental atresia, because as we know, initially the vagina will develop as a solid cord, and then by fifth month of embryological life there will be free canalization, okay? So if you see a bigger blockade, you will say this is segmental atresia. If you will see something like this, like here is just one
This is
line, you will
septum.
see that there is septum, okay? So septum
This is
can be
transverse
anywhere.
septum, Dr. Asha? Transverse?
Yeah, this is a transverse vaginal
Transverse
septum.
vaginal
It can
septum.
be longitudinal also, and if there is longitudinal one, then you will have to think about other problems also. Maybe the cervix is also, but these vaginal abnormalities, they can occur independent of other abnormalities, because their vagina is taking origin from different parts. The lower two-third from the urogenital sinus and upper one from the Mullerian tube.
Yeah, they can have renal anomalies in 40% of the cases.
Yeah, 40%. So you will, what should be the next investigation? Renal
We
ultrasound.
will, yeah, renal ultrasound.
So if inconclusive or they are still having some suspicion, then you can send patient for MRI. So then if we talk about other causes of primary amenorrhea, first you will exclude local causes, and then you will go to other syndromes. Like maybe there is agenesis of vagina or uterus, which can occur in cases of Mullerian agenesis, and or which is also called here
KH, yeah,
KH,
MRKH,
right?
yeah,
So
Mullerian
MRK,
Rokitansky Custer Hoster
Hauser,
syndrome.
yeah, Koster-Hauser syndrome. So she will have breast development because she has normal ovaries, and she will have normal pubic and axillary hair. And the fault here is that during embryological period, two Mullerian ducts will be there. First, they will fuse and they will form tubes, fallopian tubes, uterus, cervix, upper one third of the vagina, and then later this area will undergo recanalization. Sometimes these tubes they fail to fuse or they fail to develop, so this patient will have no uterus, or maybe this will be like very tiny uterus, and the part of the vagina will also not develop appropriately. But these women, they will have normal pubic and axillary hair, and on karyotype they will have 46XX
XX. Yeah.
makeup. Okay. Second thing is old name was testicular feminization, but now we use just androgen insensitivity syndrome.
Sensitivity syndrome. Yeah.
So there will be X-linked defect in the androgen receptor, and uh, all over the body, hair growth is dependent upon the level of androgens. Okay, and for the development of male external genitalia, you need dihydrotestosterone. That is the active form of testosterone. So here the androgen receptor is defective. So for the development of external male genitalia, we need androgens. But here the receptor is defective, so these children they will have ambiguous genitalia. And in the absence of, since there is no testosterone, so all of these androgens they will develop along the line of estrogen. So they will have this breast development, and pubic axillary hair either they will be scanty or they will be absent. Okay, and the genetic makeup will be 46XY. Okay, so which one is more common, Mullerian agenesis or MRKH or androgen insensitivity syndrome?
I think MRKH.
MRK,
Yes, that is more common, 1 in 5,000, and androgen
running
in
50,000, I
1,000.
think.
1 in 10,000, I think.
1 in 10,000. 1
In
in
10,000.
10,000, these figures are quoted in strategy. So that's why, the number of transgenders is very high. That's why now they are campaigning for their rights and their right to get some treatments. Uh, what are what treatments do they need? Because both of them they are going
In
to
this,
have
yeah, they this
enough.
and androgen insensitivity basically they have like not proper gonads, so they should be removed when she has attained the puberty, and they can because they can develop into cancer. Then when
Yeah,
we remove the gonads, they will need the hormone replacement therapy, and as the vagina is short, so they will need vaginal dilators or vaginoplasty, and also psychological
insurance.
consultation,
Yeah,
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 reassurance. And sometimes we
reassurance.
have to do some procedure surgical like for vaginal reconstruction, vescity, or I don't know, vaginoplasty. But
Yeah,
this is rare.
yeah. They will not ask you about the details of procedures or the time of these surgeries, but you should say that the aims of therapy in both cases are that they should be able to achieve a
Yeah,
satisfactory course, and
sexual
for
life.
that we need to
Yeah,
elongate their vaginas, and the people with MRKH they can have their genetic children, but since they don't have a uterus, so they will need the help of a surrogate.
surrogate. Yeah, surrogate. Both will
Then
need adoption and surrogacy.
adoption surrogacy. In cases of androgen insensitivity, since they will not have ovaries, so they will have to adopt babies. Okay, and in MRKH also, you have to elongate vagina, and then you will have to refer them for CBT, and it will depend on their wish that they want to stay like this or they want to change their gender. It's up to them. But psychological reassurance is required. Okay. So Dr. Asma,
Me or Dr. Zahida?
Dr. Zahida, sorry, yeah, Dr. Zahida. Dr. Zahida, your turn. So actually, you know why I am showing you these pictures? Because in the RCPI skill station, what they do, they will simply bring these printouts. And sometimes they will show you laptop screen and they will ask you to comment on them. So here are different uterine anomalies. They don't ask you that how they have developed or how these can be fixed. They just want you to identify and tell them that what can why what type of problems this sort of abnormality can cause in the females. Okay, so can you please comment on these abnormalities?
The last, starting from the first one is hypoplasia or ergenesis. Hypoplasia or ergenesis, as we mentioned now, it could be the Merck's Mayer-Rokitansky syndrome, in which the uterus tubes, cervix, and the upper third of the vagina can be hypoplastic or it can be absent. So the second one is a unicornuate uterus. Unicornuate uterus.
Yeah, it can have, unique carnoid as such. It will not cause any problem if
Any
there is
problem
a
as
unique
such, yeah. Mm-hmm.
But the problem will come if it has a
If it is
community.
non-communicating, yeah, if it's a non-communicating type, then they may come with a swelling in the abdomen, the thing, and severe pain, and so in that condition, you will have to go for the laparoscopic removal of it. And even in communicating, sometimes the cornual pregnancies are also high. Then the bike, yeah.
Yeah, please continue. Yeah.
Then we have the bicornuate uterus. Yes, cases have been reported with the second trimester miscarriages with the bicornuate uterus, and can go for the resection of the septum in case of recurrent miscarriages. Then, doctor, can you just come down? I can't see the beneath one. Yeah. Then the septate uterus, partial and complete. The subseptate uterus, again, is risk of miscarriages are high. Sorry, in the septate and the subseptate, complete and the partial septum. In case of such condition, according to the guidelines, I think we can go for the septal resection if we identify this. Then coming to the arcuate uterus, yes, increased incidence of breech presentations, especially in arcuate uterus. Abnormal presentations have been reported with arcuate uterus. Then the last is a DEC, drug related, where there is a genesis of the vagina.
Okay, when you say that we should remove this septum, that will be done only in the clinical trials. Okay, we will tell the patient
Okay.
that with each loss, it will increase. The duration of pregnancy will increase, and it is possible for her to have a normal pregnancy. Maybe she will have like 2, 3 miscarriages, but with each experience, the size will, this cavity will enlarge. So we will do septal resection only in cases of RCTs when we are doing. Okay.
Okay.
So communicating horn, ectopic pregnancy can develop. Non-communicating, menstrual blood can collect, and there can be pain. Okay. So here there is no cavity, and here you cannot see any other horn. Okay. So the problem with this sort of uterus will be that the patient can have late second trimester miscarriages, or what else they can have, or they can have preterm labor and delivery. That is the problem. So then go to this one, please. Okay, separate you have mentioned. Okay, the separate usually will not cause any. If it is complete, then it will cause miscarriages. Otherwise, usually you will not. They are not even recognized. Okay? Arcuate not associated with any symptom. So what about this didelphys? What can happen in that?
Uterus didelphys.
Yeah, so Diadelphys patient can have double uterus, double cervix, and they can be it can be associated with other with vaginal septum also. So and it will be discovered only accidentally. And patient can have pregnancy in any of the wombs, okay, and she can have she will have if there is no vaginal septum, she will continue having bleeding in the same normal pattern. Okay, she will not have any
Okay.
significant morbidity or any other problem. That is the point. So what about bicarbonate?
Bicornuate uterus, again, abnormal presentation can be there with bicornuate uterus. And
Um, abnormal
even the
presentation,
miscarriages, yeah.
preterm labors and delivery. That is the point.
Yeah.
Okay? And if it is like complete and patient goes into labor, this is undiagnosed. She will have late second trimester miscarriages, and that's why it is mostly it is just diagnosed accidentally. But there is a special group that those mothers who took diethylene bistrol, their children they can have hairpin size of this uterine cavity. So they can have miscarriages, or if there is blockage, they will not be able to have cheap pregnancies. So if they will show you, they will show you this didelphys, this unicornuate, or this bicarnuate uterus. Okay? Because they will show you something where you have a chance to do something. Okay, that is the point. They will
And
not
usually they have, Dr. Aisha, they have cervical incompetence common in them.
cervical incompetence. Yes, there will be
And
because
unicornuate, yeah, unicornuate, I have seen patients like coming with breech presentation every time,
yeah, yeah, really. They will have malpresentation and they will deliver usually at 32 between 32 to 34 weeks. That is the point.
And didelphys also, I think, usually difficult to deliver. Normally they go for cesarean, I think.
Yeah. They go for cesarean. Sometimes, I have seen them delivering, but they will take a long time, and then they can also reach. They usually they will not be full term. They can go for preterm labor and delivery.
Preterm delivery.
And
And they can rupture also, I think, easily. Uterine rupture is common in them.
yeah, they can also rupture, but we don't have exact number evidence from the studies. We don't have exact statistics on that thing. Just to say that this is double this one. And why it is like that? Because the tubes they didn't fuse or the septum was not removed. So the tubes didn't fuse, and then they have developed independently, and then the result is two uteri, two and two cervices. That is the problem. If and then in the upper part of the vagina should also be double because that is developing from the Mullerian tubes. Usually, they will not ask you about more complicated things. There will be something will be abnormal and they expect you to answer them, but they will not go into like all details. You just need to tell them that preterm labor, malpresentation, and rupture uterus during labor. Okay. So can we go to the next station for Dr. Triha? So this is X-ray of a fetus. Can you see any abnormality here? Okay,
There
let's go
is
to the next.
1 minute. Can we see
Look,
down? Because,
yeah,
okay, this is
look at
diaphragmatic
the,
hernia.
these are ribs. Okay, I will show you
Okay,
other
this is like, I think this is rickets because these are prominent, this
prominent.
rosette. Yeah,
Yeah,
rosette. What?
but this is a newborn baby. Okay, look at the bones.
Newborn,
Okay,
yeah.
if the bones are
Yeah,
constricting or breaking. Okay, or small. Look at this one also.
yeah, this
There
is
is bending of the
deformity.
bones
Yes, yes. So this is
and
rickets.
blue sclera, osteogenesis imperfecta.
Imperfecta. Okay, okay. Skeletal dysplasia. Okay.
Yes, skeletal dysplasia. Okay, that is the point. So osteogenesis imperfecta
Imperfecta,
or
yeah.
achondroplasia. So actually, your two is from this blue sclera.
Yes, yes.
Okay, that is the point.
I
So
don't.
they will,
There is a name for it, Hurler sign or something. I don't know. This
yeah,
blue
the name,
sclera.
yeah, blue sclera, yeah, I will agree with you, but they will not ask you about the names, they will just show you a X-ray, and they will ask you what's wrong with this baby. So here maybe these are broken bones, these are malformed bones because the appearance is abnormal, okay? Here, even if you will look at the vertebra, they are somehow fine, better, but here you have these problems. So they can show you any kind of fetal congenital abnormality. This is rare. They will not show you, but I just wanted to draw your
They are
attention that they
short
can be
bones also.
diagnosed.
Bones are short and they
Yeah,
are
bones
bent.
are achondroplasia. Maybe the head was fine, but the rest of the bones are small. The long bones, okay? The long bones are there affected. Then look at this one. These are bending because there is
Bending. Yeah.
no proper calcification of the bones. That is the point.
The type 3 is, I think, fatal and it is not compatible with life. I think this
Yes.
type 1, they are compatible with life.
Yeah, these are compatible with life. This they call it brittle bones syndrome also. So you can imagine that very hard to survive because the bones are breaking
Yeah, they have
and we don't
fractures.
have any treatment yet. Here, they can show you a picture like this. So of course they will not ask you to comment on all of these. Okay, there will be some abnormality here for us. The abnormality of concern should be of interest should be if this patient is a sickler or not. So hemoglobin electrophoresis, that's how our a strip.
But this
That's what.
HBSC will be the carrier and this SS will be the disease and
Yes, sickle cell disease. See here,
sickle cell disease.
SS.
And
So if he will show you a strip, this information will be missing here. Okay, but this one will be there
normal
because they're
AA
telling you
normal.
what type of hemoglobin is there. So you should know about that. Just one picture, not in detail. Okay.
Sickle cell
So
trait.
there, if you will go on this one, AA, it means normal adult
Right.
hemoglobin. So the chains, beta chains are there. So this is hemoglobin A, adult type. AF, this is there you are going to see gamma chains. So this is fetal hemoglobin. And if there is hemoglobin S, so it means sickle cell is there. So there can be various combinations. AS means there is adult hemoglobin and there is sickle cell hemoglobin is also sickle cell hemoglobin is also there. So AS means sickle cell trait. If both genes they have mutation, then hemoglobin will be of SS type. So this is sickle cell disease. If AC, hemoglobin C trait. CC, hemoglobin C
C
disease.
disease.
S, hemoglobin SC disease. So don't be upset to see anything like this, right? Actually, in the last two exams in the MRCPI one, they showed them electrophoresis, hemoglobin electrophoresis strips also. Okay? So if they ask you what is this, then you will say on a gel, hemoglobin migrates from the negatively charged cathode to positively charged anode. So hemoglobin A, it migrates the farthest. It is reaching the farthest point from the start. So that's why whenever you will see something here, it means that this type of crate is containing adult hemoglobin. So it is followed by hemoglobin F and then hemoglobin S and hemoglobin C. It will stay close to the cathode. You don't have to go into details, just remember this one, and I want you to remember these combinations because if in the exam question, even in the short cases, they give you that her hemoglobin electrophoresis was done and found to be AS or SS, then you should know at least that what exactly they want you to talk about. So what do we see here? So Dr. Zahida, this picture, I will try to enlarge this one for you. And this is a normal RBC, okay?
Yeah,
And
this
this
is
is a
sickle
I
cell.
can't see. Can you just get it this side? That's I think I'm using. Yeah. Okay, that's fine. I can see it.
see that is sickle cell.
Yeah,
So,
the
what
sickled
is the
cells. Yeah.
so you you say this is sickle cell.
Yeah, it's a peripheral smear, right?
Yeah, it's a peripheral smear, and here are
Showing the
normal
sickling cells.
sickle shape, so sickle cell disease. So what will be the hemoglobin pattern in sickle cell disease?
Disease
Normal.
is SS, and trait it can be anything, AS or AC,
So here they
or
are only
SC.
asking
Yeah, yeah.
what
But
is
they
the
are usually normochromic and normocytic.
yeah, normochromic, normocytic. These are the things. So about the sicklers, we will talk in detail later if we are doing some short case. So this was only for the sake of identification. Like they can show you many things. Okay? Usually, you know, the things will be common, but you should have some idea that what sort of things they can show you. Okay, so that you are not surprised. So what is this? What type of disorder is this one? Hemoglobinopathy. What has gone wrong here? Glutamic acid has been replaced by another amino acid which is called valine. So
Valine.
what happens? Valine. So what happens? If there is less oxygen saturation, this hemoglobin it will crystallize, and then it will adopt. The cell will change into a sickle shape. It will change its shape into a sickle, and then the problem is that these are because of this crystallization, it cannot pass smoothly through the capillary circulation, because to pass through the capillaries, the diameter, maximum diameter should be 6 micron. And now it is more than, if you will compare it with this one is a bit larger, so it cannot pass through the capillaries, so they will clog the capillary, and that's why they can cause micro infarction and destruction of the tissue. And due to very same reason, they can cause venous thromboembolism also. They will ask you about the basic defect. Then you know in the
If
OSCE
we
very
if we cannot recognize, Dr. Aisha, how many we should pass? Like to pass the station, how many we need to recognize?
you know you have to pass the station overall, and out of 7 stations you should pass 7, but trust me, you will see very simple things like yesterday we talked about this Tusco speculum. Then this dye test in perforate hymen, the test results like the patients had some abnormality. So you know nobody can remember all normal reference ranges. So just compare, don't be confused. If you don't know about anything, just simply say sorry, I don't know much about it. Because if they are giving you 10 marks and you couldn't identify like 2 or 3, so anyhow you have identified 7, so you will get 7 points for that. Don't worry at all. Okay? So your aim is to pass the short circuits in aggregate. Don't worry, and the things are going to be very simple. I have taken out the complicated things because the simple things anybody can comment on them. But these hemoglobinopathies, people have a lot of confusion on them. So thalassemia, uh, you should just remember there can be patient can have alpha thalassemia, can have beta thalassemia. So in alpha thalassemia, alpha globin gene deletion. So alpha globin 1 globin synthesis will be defective. You just need to remember only this first line. No one is ever going to ask you about it. So the severity of the disorder will increase as the number of affected genes will increase. Even 2 genes they have been affected, still it will be a thalassemia minor. There will be. In the first one, when just one gene is defective, no anemia, so person is a carrier. If they have 2 defective alpha genes, they will have mild microcytic anemia. Then as the number of abnormal chains will increase, they will have problems, and if all 4 chains they are defective, then this is incompatible with life. So we call it Bart's hemoglobin, Bart's disease, and the baby will die. Why? Because he cannot carry. Just remember in alpha thalassemia, defective or decreased synthesis of alpha globin chains. Decreased synthesis of alpha globin synthesis. 4 chains are there. 1 chain is abnormal, nothing. Carrier. 2 chains are abnormal, yes, mild anemia. And then severe anemia, and then fourth condition, incompatible with life. So similarly, if they give you beta thalassemia, your patient can show absolutely normal findings, or they can show microcytic hypochromic anemia. So there are point mutations in splice sites. You can say there's some slight mutations in the hemoglobin, and there will be defective synthesis of beta globin chains. So it can be minor, where the patient will be heterozygote and beta chain is underproduced. So how do we diagnose? Diagnosis is confirmed by increased level of hemoglobin A2 chains, and they will be like more than 3.5%. Dr. Pia, you were saying yesterday 2.5, so
Yeah, this
2.5.
always they are giving this, in this they are mentioning this HbA2 always.
Yeah, so that is it will be more than 3.5, more than 3.5%, but the range is that it can be better. Some books say that it will be 2.5. So just remember 2.5, 3.5. It means beta thalassemia minor. In beta thalassemia main, beta chain is absent. Here in beta thalassemia minor, it is underproduced. And in beta thalassemia major, this in the homozygous, beta chain is absent. So patient can have severe microcytic hypochromic anemia with target cells. Target cells are broken cells, and the cells can be of abnormal shape also, and these patients, they will require blood transfusion. Then due to blood transfusions, they can deposit extra iron into their system, so they can have secondary hemochromatosis. Why? Because blood is breaking down, and iron is depositing into several organs in the body. So they can have skeletal deformities, they can have facial changes, they can have extramedullary hematopoiesis, there can be hepatosplenomegaly, increased risk of parvovirus B19 aplastic crisis, and sometimes, they can have more fetal hemoglobin also. So if more fetal hemoglobin, this not more fetal hemoglobin, I want to say that in the first 6 months, the babies have higher level of hemoglobin F. So that's why we won't diagnose them, but after that they will become symptomatic. So we are interested in thalassemia during pregnancy, how it affects us. But to build up your concept, you already have good concepts. You should remember your basics. What is abnormal? What is happening? So at least you should understand if they tell you hemoglobin A2 is more than 3.5. So beta thalassemia should come to your mind. Audit. Many people are very upset to see an audit. We will practice with audit. This is just the smallest, shortest possible summary. Okay? If you forget everything, then just say these points and you are going to be fine. Of course, we are going to talk about audit in detail, but I have summarized this one for you. Because on the skill station, they can give you an audit and ask you to comment on that. So you should say clinical audit is a structured process to continuously evaluate and improve the care received by the patient. So purpose is to improve provision of care. It is not done to convict someone or to cause any problem for anyone. So audit cycle, it involves that you should establish criteria and standards. What is the problem? Then collect data, input data, analyze data against criteria and standards. Then you should report and summarize your data. Then, in the light of the findings, you are going to create an action plan. Then you will implement change. And then at the same time, you will decide that when you are going to review your practice again. So you can either fix a time limit, like you can say we are going to review after 2 years, or you can set a number of patients. Like you can say that we will review our practice once we have done 200 cases. Okay, but mostly duration is used, and usually it is better if you can re-audit after 2 years. Then you will do re-audit, and if you have seen significant changes, you will make that part of your permanent protocol. So we'll talk about that in detail. So this was just a test. I just wanted to show you that how many different types of things can be asked. We will practice with more stations also, don't worry. So any question, any problem so far?
No, it was very good and clear.
Okay, that's good. So let's have a break for 15 minutes. Then we will try to do a circuit, and then we will do certain other things. Okay. So take a break for 15 minutes and then please join by using the same ID.
Okay. Thank
Thank
you.
you.
See you, yeah, see you all in 15 minutes.